Good morning, everybody. Let's start this webinar. Welcome to this World AIDS Day webinar, which is jointly organized by the Sosui Hock School of Public Health, National University of Singapore, and UNAIDS. We have several speakers this morning that will speak for about 10 minutes each. And the Q&A session will be at the end after all the panelists have spoken. So please write your questions in the Q&A box that you have at the bottom of your screen. We have a host and moderator this morning that I would like to introduce you to is Dr. Sian Yi, assistant professor at the NUS School of Public Health. And Sian is a global health researcher who has worked in the community and particularly in Cambodia. And he's worked on several different topics, including HIV in the past. So he'll be the one taking you through this webinar today. So over to you, Sian.
Thank you very much, Alicia, for your kind introductions and the instructions. I think everyone's now we have more than 100 people on. Welcome everyone to our webinar. Alicia just mentioned today webinar was jointly convened by our school, Sosui Hock School of Public Health of the National University of Singapore and UNAIDS Asia Pacific to commemorate the 2021 World AIDS Day. The themes of this year's World AIDS Day is End Inequality and AIDS and Pandemics. This year, UNAIDS is highlighting the urgent need to end the inequalities that drive AIDS and other pandemics around the world. To be aligned with these themes, our seminar will focus on ending inequalities to end AIDS and pandemics, HIV prevention and response in Asean. This World AIDS Day is an opportunity for us to look back at what we have done in the past 40 years since the first HIV cases were reported in 1981 and set priorities for further action against the epidemic. Without further ado, I would like to invite Professor Teo Eng Eng, Dean of Sosui Hock School of Public Health of the National University of Singapore, to deliver a welcome remark. Please, Prof. Teo, the floor is yours.
Thank you very much, Sian. A very good morning to all for joining the program that UNAIDS and the School of Public Health at the National University of Singapore have jointly put together. I think it's really great to see faces of longtime friends again that we haven't had the chance to meet for a while because of the pandemic. But precisely because of the pandemic, this has ironically facilitated the acceptance that meetings and workshops like this can still be held. Ideas and opinions can still be exchanged, valuable lessons can still be imparted in a manner that perhaps minimizes travel and its impact on the climate and environment. NUS and UNAIDS came together formally as close partners in January 2020 during PMAC, the Prince Mahidol Award Ceremony Conference in Bangkok, just right at the beginning of the COVID-19 pandemic. And at that time, we had a clear message that was unanimous to jointly tackle and address the challenges that HIV/AIDS have posed to societies and communities in Southeast Asia through a partnership between academia and the UN program specifically tasked to accelerate and coordinate global action on HIV/AIDS. And what many people didn't know, besides this community that we have today, the public wouldn't know that the scale and reach of HIV more than qualify it to be a global pandemic, and that it has been so for the past 40 years. And perhaps because it has been around for decades, there is a general sense of detachment and acceptance that HIV/AIDS is just another global public health problem, the misconceptions that it affects mostly the poorer nations and only people with the wrong behavior. This has regrettably resulted in the wrong attitude in many cultures and societies, which inadvertently has driven a lot of disparities in managing, preventing, and even educating people properly about HIV/AIDS. This inequality has directly contributed to worsen the situation in many countries and in many cultures. And even in countries that have adopted a more informed and evidence-based approach towards tackling HIV, rolling out, implementing prevention, detection, and clinical management programs in the community has also seen many challenges that have resulted in inequities in outcomes, such as those linked to equitable rollout of universal health coverage to include HIV/AIDS care, the rural-urban divide in accessing regular health services, and definitely the uniform and consistent rollout of culturally sensitive educational messages of prevention. Now, the problem with COVID-19 has resulted in the diversion of tremendous amounts of resources and efforts away from problems such as tuberculosis, HIV/AIDS, and malaria. And I think there is a need to remind people and the world that the global public health challenges that I have talked about, including antimicrobial resistance, actually have not gone away because of COVID-19. I'm thus very glad that this joint webinar will seek to address many of the prevailing issues that continue to drive inequalities as well as inequities in HIV/AIDS programs, not just nationally, but internationally, regionally, and globally. And I hope the speakers, panelists, and attendees will benefit from today's program. And I thought I should also mention that Professor Hsien Yee from the School of Public Health will be moderating the panel session, and he actually leads a collaborative research program between NUS and the Cambodian University of Health Sciences. But more importantly, Hsien is the director of the Center for Population Health Research at CANA, which is the largest national NGO providing integrated HIV prevention, care, and support services in Cambodia. So I think, Hsien, you will be very well tasked to moderate the panel discussions that we have moving forward. So with that, over back to you, Professor Yee.
Thanks, Prof. Dear, for your warm welcome remark and insightful introductions and additional kind introduction to me to the audience. Next, I would like to invite Mr. Taufik Bakali, UNAIDS Regional Director for Asia and the Pacific, to provide an opening remark and overview of the HIV epidemic in Asia and the Pacific region. Please, Mr. Bakali, the floor is yours.
Thank you so much for this introduction, and thank you, Dr. Theo, for the very inspiring words introducing the topic of this event. We are equally proud and pleased of this partnership. Over the past couple of years in these difficult times of COVID, and very pleased and happy to see this event happening, bringing fruit to this collaboration and strengthening it or moving forward. I'm going to speak on the theme of World AIDS Day and introduce some concepts why we are having this theme, inequalities, ending inequalities, and AIDS and pandemics, and what's the intercorrelation about between all of them. And this talk, I will try to ground some evidence to give some context to the discussions of the panelists, and go over all these issues and show the links, how they translate in reality based on evidence and data that we have seen over the past recent years. We know where we are on the HIV epidemic. It is now known and established that globally we have missed the 2020 global targets for the response to HIV, globally, but also regionally. The pace of decline in new HIV infections as the ultimate goal, as well as AIDS-related deaths, has slowed down over the recent years. And particularly if we see in Asia Pacific, where our performance is less than the global average, it's interesting to note how Asia Pacific was doing so well in the early parts of the decade, around the year 2000 to 2010, where you can compare and see that the rate of infection has declined strongly, but then it slowed down. And continuing in this trend, even now, it's clear that we may not be able to achieve the global target of 2030. But then we need to understand what this means and why we are having this slow decline. a little bit of analysis looking by countries, that's always the risk of doing aggregates of big countries in a very large region in Asia and the Pacific, you would see that we have larger inequalities, if I would say, between all the countries. The country names colored and in boxes are representing Asian countries, and you can see the spread, you can see the varieties even within ASEAN. We are covering up the whole spread of performance from the best performing to the countries facing the maximum challenges with regard to reducing new infections and with regard to reducing AIDS, which tells us, AIDS-related deaths, which tells us that there is a lot more that needs to be done, and then that the countries are facing different challenges in different ways. But the one thing that all these countries face is the one nature of the epidemic, which is mostly focused on key population and their partners. When we see 94% of all estimated infections are happening among key populations, sex workers, people who inject drugs, men who have sex with men, transgender women, and their clients as well and partners constitute the majority of the infections. Now, it is interesting to note, and that's where the concept of inequality comes in very strongly, that these populations in almost all these countries are criminalized. And then when you have those populations criminalized, of course, you can imagine the level of restrictions that they may be facing in accessing services to prevent or to treat, to prevent HIV infection or to treat the HIV infection. We have seen as well that these populations, because also of their status, and at the time of COVID, they have faced increased vulnerabilities and restrictions for accessing social protection or any kind of food or initiatives that would alleviate the impact of COVID on all populations whenever they are happening. We all know very well how COVID impacted on all strains of life in all countries, particularly here in this region. Now, with these populations being criminalized, associated to a very high levels of risk, as you can see, key populations, this is global data, and we have very slight variations as they show up in different regions. But you can see when you have up to 30 times higher risk of HIV acquisition than general population, or 13 or 26 times. And at the same time, we see tendencies that due to criminalization, many of these populations are being put in prisons where they may have access to treatment if they are HIV positive, but they do not have access to any kind of prevention. So these restrictive laws and policies create rather increased risk and further widen the inequalities for accessing HIV services, particularly in prevention, no matter how the interventions are happening within the framework of those laws and policies, which push these people further behind and keep them at risk. Now, the result is, we should not be surprised in seeing this. When we consider that each dot represents the prevention coverage for specific population. We have 4 colors here representing the 4 populations. The majority of the cloud is in the left side below 50% coverage. Sometimes we keep saying why we cannot increase. The country is not doing the effort, but it's a combination of issues that includes the laws and policies, as we just mentioned, but also includes the issues around models of services, around adaptation of those models and the package of services, and how they tend to, or they attempt to reach the population that are in need of those services, rather than going with a single approach of considering a scale up of something that is not adapted or not accessible to these populations. Now, when we see that these the key populations are left behind and face serious inequalities, including from policy and legal aspects, but also programmatic, within those key populations, we see that there are some categories who are further left behind, facing even stronger inequalities for accessing services. And you see here, for example, if we consider only the length of age, we see how the young key populations are even left further behind and not able. It's striking evidence that tells us that sometimes the inequalities need to be analyzed in a specific way that allows to understand who is left behind. We cannot assume that all populations are harmonious, and that everyone will be reached by one type of service and one type of policy. It is important that when we look at the inequalities lens, we use the inequality lens that we consider from different perspectives who are left behind, from age perspective or from economic perspective or from gender perspective or any other. And you can see that a little bit of analysis would tell us quickly why. Now, question, is it really due to inequalities or something else? We have the proof. And as we can see in this slide, that tells us in the left side how the share of infections among young people is taking great importance and prominence in countries. At the same time, we see how many countries are allowing easy access for young adolescents and young people to access services. And we see a lot of restrictions. These aspects of flows and policies and regulations are what leads to these kinds of inequalities and preventing people from accessing services. And that's not a surprise that we see new infections among young people increasing, or the incidence at extremely high level, even 4 times higher than the incidence of among the older peers. So young people in this generation go online, of course. That's the tendency, particularly in COVID, when there is restrictions on physical gatherings. People started, or even increase. There was an increase of using of online tools for networking. But at the same time, these online platforms and the virtual space also offers great opportunities and great solutions. We have seen how virtual outreach interventions have allowed to reach the most at risk and have helped identify people who were unlikely to access any testing services or even not able to be linked up to treatments. We have concrete examples coming from within ASEAN countries, also in the Philippines, in Cambodia, and many other countries. The virtual interventions has helped also alleviating the COVID or mitigating the COVID impact on populations and ensuring stronger linkage to services. Now, if we look at the treatments, we all know this background, and a little bit of analysis tells us that while we see that the largest share of new infections are happening among men and who have sex with men, particularly, and their partners and the clients, we see that the men are a little bit left behind when it comes to the treatment cascade, linkage to treatment, access to testing, and also achieving viral load suppression. But very worrying to see how the trend has evolved, particularly in 1920 at the time of the COVID, how the achievements we were having in the past few years in terms of annual net increase of people on ART has tremendously slowed down from 14% to 5%. And when we analyze further, we find out that over half of the countries are either seeing a gap widening, so we are no longer moving towards closing the gaps. We are seeing COVID bring in a risk of the gaps widening, or at least not changing, including countries who have been performing very well. Every single country, with very few exceptions, 2 or 3 in this region, the others have all seen lower net increase on treatments in the past year compared to the previous one. Now, we all understand that there are strong inequalities, and that's why strong intersectionality between HIV and COVID. They impact the populations in the same way. They build on same challenges and issues and inequalities. They highlight when people are left behind, and they increase the vulnerability. from whichever way you see it, including issues of access to social protection, of inclusion, and also in terms of impact and how it means on increasing the issues around homelessness, unemployment, income, access to services, access to social protection. So this is why it's important to consider that linkage on responding to HIV and responding to pandemics by considering the solutions that we have seen popping up and proven to be extremely effective in the region that have established themselves in response to COVID. We have particularly the community systems who help to bridge the gap in first ensuring continuity of HIV interventions, but also in helping in bringing the most affected and marginalized populations to have access to social protection, to have access to cash transfers, and to have access to COVID, including vaccine programs. We have evidence from countries where community-led organizations have facilitated access of their community members to vaccines, which otherwise they would not have access. And we have plenty of excellent examples where community leadership had a major effect, not only on continuing the HIV services at the time of lockdowns and closing and restrictions, but also helped in strengthening the response to COVID itself by alleviating its impact and ensuring access to the services. Now, when we see all this, we realize that all these recommendations in the Global AIDS Strategy and this push around ending pandemics comes at the time of a resource gap, a serious resource gap that we still see globally. And this is data with regard to Asia and the Pacific. And you see that the resource gap for being able to achieve the global targets is even higher than the resources that are being invested. And this becomes even more challenged at the time of COVID. Is it really a challenge? Well, probably it also brings an opportunity, because we've seen that the investment on the systems for health that are not only in health, particularly community systems, has a double benefit of first improving the performance on the HIV response, but at the same time helping in responding to COVID. So it is an investment, whichever way it is counted, under HIV or under COVID, but it helps build the mechanisms and the systems for both responses and helping to achieve the global goals and targets, particularly for HIV, as reflected in this context in the Global AIDS Strategy 2021-26, which has put reducing inequalities as the center of its whole design, looking at the policies, looking at the systems, looking at services, and ensuring and setting up clear targets that would allow for achieving the global AIDS targets at the time where we all globally, we are facing serious challenges that are due to other pandemics, when we all recognize that there are very strong intersections between the HIV response and other pandemics, when some people or categories of the population are left behind. I will stop here and thank you so much for your attention.
Thank you so much, Mr. Beckley, for your brief but very insightful talk. I like your slides a lot, and I think it would be very helpful for us to use in the future. And it would be appreciated if you could share your slides to us, with us later on. That's very interesting. Thanks so much. Unfortunately, we do not have time to kind of further discuss on this. We have to move on to our panel. Now, we have come to the critical sections of the webinar, which is a panel. Today, we are honored by the presence of many people who have been at the front lines in the fight against HIV and health inequality among vulnerable and marginalized populations. So today we have 4 panelists joining us to share their insights regarding underlying social injustice a long-standing global promise in the Sustainable Development Goals and the Global AIDS Strategy 2026, and the potential resolution to tackle this issue. We will have approximately 30 minutes after the panel for Q&A and discussion session. So please feel free to drop your question and comments in the Q&A chat box. Dr. Rita will help me select the question for the panelists. First, let me invite our first panelist, Professor Adipa Kamruzzaman, the president of the International AIDS Society. Dr. Kamruzzaman continues to serve as a professor of medicine and infectious diseases at the University of Malaya and adjunct associate professor at Yale University. She was the dean of the Faculty of Medicine of the University of Malaya from 2011 to 2019. Prof. Kamruzzaman will highlight the harnessing digital technologies in prevention and treatment program. I believe these are very important for the current, in particular during the current emerging and re-emerging pandemics. Please, Professor Kamruzzaman, the floor is yours.
Thank you very much, Dr. Sian. Just let me, excuse me, put my slides up. I had trouble navigating this Zoom thing. I can't seem to make it go. Aha, okay. Give me 2 seconds. All right, can you see the slides now?
Yes, it looks good. Thanks.
Okay, great. So I'll just, first of all, let me thank both the NUS School of Public Health and UNAIDS for inviting me to be part of today's panel. And I'm just going to take on where Taufik left off in terms of the barriers and challenges we here in Asia and the Pacific have in order to reach the ending AIDS goal. Taufik has already outlined the many factors that have led us to kind of fall behind even before the COVID-19 pandemic struck us. Well, globally, we know that one of the reasons why we have not been able to achieve the global targets is the inequalities that have been outlined by Taufik, and particularly more so here in Asia and the Pacific, with many of those affected or at risk belong to key populations who are extremely marginalized, stigmatized, and discriminated against. We have so many tools now to end AIDS. We have effective treatment that has been around for decades, that's getting better and better with effective one pill treatment, soon to be just 2-drug regime, and even long-acting formulations that are going to be helpful in certain individuals who may not be able to adhere, both for treatment as well as prophylaxis. But despite having all those, we're still falling behind. So what can be some of the interventions that could enable us to scale up both treatment and prevention much more than we're able to do at the moment? And certainly COVID-19 has given us an impetus to embrace digital technology much more than we have. I sometimes say we in the health profession are perhaps too conservative and too slow. When you think about how the financial and the airline industries have embraced digital technology, we're really far behind, aren't we? When was the last time you walked into a bank, and we do everything online? We don't even have to queue up at airports anymore because we can check in online. But in health, we haven't scaled up like our partners in the airline industry and the financial industry have to our disadvantage, I guess. So digital health has so many uses in both treatment and prevention of HIV, and here's just the kind of summary of what's possible and what have been tried all over the world, mostly in advanced upper middle and upper income countries. So for diagnosis, you have the use of mHealth and others for self-testing, linking to counseling and partner services or disease intervention. In prevention, likewise, digital health can be used for risk reduction counseling, linkage to care, PrEP and PEP, virtual appointments, similarly for treatment and the overall response, including telehealth, as well as capacity building of public health workforce. So the opportunities for expanding digital health are limitless when you consider it. So in terms of telehealth models, you have HIV self-testing that can be utilized at every step of the cascade, from reaching out to those at risk, to referrals, to the actual testing. And I'll share with you our project in terms of HIV self-test and counseling by web, done by the Malaysian AIDS Council, and subsequently referral to HIV treatment or PrEP providers, and later on utilizing mHealth to also ensure treatment adherence and to encourage regular HIV self-testing for those who initially test negative. And here is another telehealth model for PrEP delivery. So onboarding for screening, again, consultation with initial clinical evaluation, counseling, obviously in-person visits needed for the conduct of lab tests, but subsequently self-test kits can be delivered by post or in Malaysia, we call them Grab deliveries. So you don't even need to go to the labs anymore with the advent of self-testing, and results can be sent to you by SMS, by WhatsApp, etc. Both provider to patient counseling and support can also be provided online by mHealth, as well as provider to provider for capacity building of either community service providers or even healthcare professionals through the ECHO program that's utilized quite widely now in both, it started off in the US for Hep C treatment, but it's now being scaled up globally for other diseases as well. So the Teleco Clinic is a communities of practice that delivers clinical mentorship. As mentioned, it was initially devised to scale up Hep C treatment in Albuquerque, but in the US, but has now been adapted for cancer care, for HIV care, as well as can be utilized for PrEP. We here in Malaysia are piloting ECHO for stigma reduction, for training healthcare providers in family care practices across Malaysia using the ECHO program, and we hope to roll this out next. So like I mentioned, the opportunities are limitless. So here's an example of an integrated HIV self-testing that's web-based. And we thank Love Foundation from Thailand for supporting the Malaysian AIDS Council to develop this web-based program. And it's a collaboration of Churia, Malaysian AIDS Council, FAO, and many, including providers of HIV self-testing. So we started with some delay because obviously COVID got in the way as we were about to roll out this program. And this is just a snapshot of what's been achieved thus far. So 21,661 unique visitors to the site. However, only a small portion of those 21,000 registered online and subsequently gave consent, and 1,000 or so, 1,017 completed the whole cascade. So through this initial rollout, we still have much to learn as to why the out of 21,000, only 3,005 eventually registered and gave online consent. Regardless of that, these are 1,000 more people who have tested, who otherwise have not been tested. As you saw from the from what Taufik shared, Malaysia is seeing a rise in the number of young men, particularly young MSM, who fear coming forward for testing, incredibly stigmatized and discriminated against. And so we hope that by providing them with this online platform to be able to do HIV self-testing and increase the proportion of people who are at risk and eventually get tested. The majority preferred, and not surprisingly, oral swab as opposed to the InSTI finger prick test. And as you can see, of those who underwent testing with OraQuick, 7% were found to be positive and 5% using the InSTI test. Overwhelmingly, of the 1,000 who tested, 77% are from the MSM population. I think this is, again, not so surprising because of, I guess, increased awareness. And we at the Malaysian AIDS Council would need to do much better in terms of reaching out to the other at-risk populations to utilize this service that has become available. I should say that the tests are free at the moment for those who utilize this program. 8.3% MSM are positive and 6% within the general population. So as you can see, of those who utilize the services, most are in the younger age group, and here's the breakdown of the HIV positivity that we found within this cohort. I think one of the advantages of these mobile platforms or web-based platform and eventually delivering the test kits to the homes of these people who order the test online is the potential to reach not just members of the key population, but in Malaysia, we're really quite hampered by presence or lack of presence of community-based organizations in some states. Not all of the states have strong community-based organizations, and we hope that by having this web-based facility that those at risk in more conservative parts of Malaysia like Kelantan, Kedah, Pahang, and Terengganu, where each state's only represented by one or so or none community-based, a strong community-based organization under the umbrella of the Malaysian AIDS Council will be able to do so. As you can see at the moment, those accessing the Jom test still are from the richer states, if you like, of Selangor, KL, and Johor. So there's still much more that we need to do to raise the awareness of online platforms to increase HIV self-testing, which, as we all know, is the first step towards HIV treatment and prevention. Now, one of the concerns is, and colleagues from Thailand showed that one aspect of mobile health is, of course, to increase the reach in terms of testing. But the second part of that is, can we ensure linkages to confirmatory testing and antiretroviral therapy after this online supervised HIV self-testing? And the answer from this study that Nitya and colleagues did in Thailand of 465 MSM and 99 transgender women who elected to do self-testing online, that there is still much work that needs to be done to ensure linkages to confirmatory tests and ART initiation, similar to the experience that we in Malaysia have had with Jom test. And certainly there have been no shortage of systematic review of technology-assisted HIV testing interventions and other kinds of interventions using technology. And from a recent systematic review of technology-assisted HIV testing, the summary was, although there appears to be growing evidence of their benefit, questions linger regarding how to leverage these social media platforms to promote testing, which interventions work for what populations, and best practices for scaling up mHealth and other technology-based interventions. So whilst these interventions are definitely the way forward, I think there's still much that we need to learn and we need to research to ensure that scale up in the best possible way happens. Another systematic review published in GIS last year also looked at electronic and new media technology for HIV care and prevention. Similarly, here the conclusion is the majority of at least published interventions currently favor education and behavior change over linkage to care, retention, and adherence, especially for PrEP. So I think we researchers and others and community service providers need to do more to understand how we can expedite this intervention and scale it up in the most effective and efficient manner. In other words, there's still much work to be done. And just finally, I think this is a study from the US looking at barriers to telehealth utilization. Again, telehealth was used widely to overcome the barriers of lockdowns during COVID-19. But again, the uptake of telehealth is not as wide and as quick, at least here in Malaysia, as you would imagine, in terms of the necessity to pivot to this form of technology. And some of the barriers include patients' inexperience was stated to be the most common barrier, daunting to patients who are unexposed to technology. Half of them replied such. There's still distrust of technology, concerns around privacy, lack of resources to purchase technology, and access to technology and wireless connection. in a quarter of those who were surveyed. Again, here in Malaysia, although, and I think many countries in the region, although the broadband penetration, although 3G, 4G penetration is reasonable, but I think broadband penetration in many countries in our region still remain a challenge. So we talked about inequalities and the barriers to both COVID-19 and HIV prevention, treatment, and care. And if we're going to pivot to digital technology to overcome that, the other big divide is, of course, the digital divide that exists in most countries in the region. So as pointed out by Taufik and others, there still remains a lot of work to be done. As Prof. Teo said, many in the region think that HIV is over, that we've solved that pandemic, but nothing could be further from the truth. I want to echo the call from UNAIDS and Taufik that we need to reinvigorate and re-energize our response to HIV/AIDS, in as much as all of us are kind of embroiled in the COVID-19 response, but we mustn't allow HIV to fall behind, the HIV response to fall behind in our effort to overcome all these twin pandemics around the world. So with that, thank you once again for inviting me to be part of this panel.
Thank you so much, Prof. Kamruzaman, for your inspiring talk about the utilizations of the digital technologies in HIV programs. I believe this is very important, or even more critically important during this pandemic. And I believe all the speakers would be happy to share the slides with us for future use, hopefully. I think we are running out of time, so allow me to move a bit faster to the next speaker. Our next speaker would be Prof. Sophia Ajuleta, who is going to share an overview of the HIV epidemic and response programs in Singapore. Prof. Ajuleta is director of the National HIV Program within the National Center for Infectious Diseases and head of the divisions of infectious diseases at the National University Hospital in Singapore. She is also a clinician educator and serves as core faculty of the National University Health System Infectious Diseases Senior Residency Program. Please, Prof. Ajuleta.
Thank you, Sian, and my thanks to UNAIDS and our School of Public Health for the kind invitation for today's webinar. Naturally, I echo the sentiments of all my colleagues here that it's nice, although by necessity, but it's still very nice to be able to bring attention back to a major pandemic like HIV, even in the midst of while we still battle COVID-19 and its new face, Omicron. So let me jump right in. I was asked to give an overview for the purposes of the panel about the HIV situation in Singapore. So I'll do that, but I won't dive too deeply. I'm hoping to save some of that for question and answer session that's coming up. So as the audience has heard and probably knows, UNAIDS set the famous 90-90-90 targets that most of the world has missed with basically a handful of exceptions. And now we're going to be moving forward towards 95-95-95. This is how hot off the press from the Singapore HIV Congress last Saturday, our Ministry of Health unveiled our data for this year's. So as you can see, towards the first target, 82% of people living with HIV in Singapore are aware of their status and are diagnosed with HIV. 93, the second 93% on ART, and 94% have virologic suppression. So quite clearly, we have met the second two, but missed the first of the 90s. How does that look in terms of the overall HIV care cascade? So this is where another way of looking at these targets, how do we look at how we're performing compared to the estimated 8,000 or 100% of the pool of living with HIV in Singapore. And as you see, the biggest drop off again is around that first 90. And that's why you'll see on my virtual background, HIV testing has to be our focus because we need to be able to diagnose individuals so they can then take full advantage of the rest of the treatment cascade. So this is the biggest drop off. Then there's a little bit of a trickle before you get to the cumulative effect of having about 73% of individuals living with HIV with a suppressed viral load. Ultimately, this meets the cumulative target that UNAIDS have set, which is that 73% of when you add up all the 390s, that 73% of all people diagnosed in your populations, in the global population, should have an undetectable viral load. So in Singapore, we've met that by a hair, but we have a long way to go for sure. So let's look a little bit more closely in what has determined what I think is success in the second 290s, but still leaves us all this room to go in the first 90. A major advance in terms of the care of people living with HIV in Singapore was in September of last year. So in the midst of COVID, some of the long-term efforts of the community and of providers and advocates paid off when our Agency for Care Effectiveness in the Ministry of Health was able to add antiretroviral therapy on our standardized drug list. What this means, or what this meant at the time and continues to mean, is that there are 50 to 75% subsidies towards the cost of antiretroviral therapy in Singapore, essentially for all people living with HIV in the country. And this has been of tremendous help. Around the same time, at the end, or a little before that, at the end of 2019, we had our first national recommendations developed by the National HIV Program and our ART work group, looking at first-line therapy and switch strategies, as well as targets of when to start antiretroviral therapy to bring us more in line with developed countries and rapid ART initiation. So again, how we did when we looked earlier in the year, how we did against the benchmark of our own recommendations, you can see here on the right that we do well in terms of the what to start. So this is encouraging, especially when we included the newer integrase inhibitors that are both in our 2019 and the current 2021 update of the national recommendations. We do well in terms of, again, what I think plays into the second and third 90. We have a strong public healthcare sector. We have facilities that provide holistic and multidisciplinary care for people living with HIV, and that includes being able to initiate and maintain antiretroviral therapy. Interestingly, this is even these gains are even before the subsidized drug list went into effect. So we expect this to continue to improve, or hope that this will continue to improve. Where again, we do less well is kind of earlier on in the cascade. So obviously, if we have gaps in our testing, we also have gaps in how quickly people get initiated on ART. And you see there's quite a range of adherence in the when to start of our recommendations. And I have to say our window of when to start rapid ART is actually within 2 weeks of diagnosis, which is quite generous when you compare it to a lot of other programs around the world. So we do have a ways to go when it comes to this one. And again, this might reflect inequalities in terms of access to care, but importantly, we think this also reflects some measure of stigma that is still pervasive, and we'll talk about that in a second as well. In other good news, this graph is a little bit outdated, but the trend holds, even though for about 10 years from 2007 to 2017, the notification rate among Singapore residents for HIV was quite steady between 400 and 500 cases. Starting in 2018, we started seeing a dip, and this trend has held to first about 300 a year for 2018, 2019, and now looking to dip below 300. There is a lot of efforts being taken to see whether this is a little bit of artifact because of COVID and decrease in testing, but the data doesn't pan that out, and the trend was there even beforehand. So we do believe this is showing some of the gains for achieving that second and third 90 of treatment as prevention, and the paradigm of undetectable equals untransmittable, but we'll have to again see how this plays out long term. So let's go back to the 390s. So again, in red, why is this first 90 not met? Well, the glass half full view of this would be that even though it's not met, it represents a great improvement when Singapore started looking at reporting the UNAIDS targets. Back in 2016, the first 90 was only holding at 66%. Whereas the second and third 90s were at 82 and 92 at the time. So there have been improvements in all three, but the biggest jump has in fact been in the first 90, even though we still have a long way to go. And how might we overcome this? I think later Rainer will speak a bit more about stigma and how this affects the community here in Singapore. You heard about this from Taufik and Adiba as well. It's still a key player, and I would argue that it impacts that first 90 more than any of the others, because even though, as you'll see in front of you, throughout the continuum of care, there are reasons why in Singapore, both in terms of our legal framework, community stigma, other types of policies and restrictions that can affect throughout the continuum. I think making that initial leap of getting tested and knowing your status is where it impacts us the most. So what can we do about this? So from the programmatic standpoint, in terms of the National HIV Program, our partners at the Health Promotion Board, Action for AIDS, and the other clinical programs, destigmatizing campaign that's bigger than anything that has been mounted before, has gone both online and in physical form at MRT stations around town. This is the one that serves us here at the, by here I mean my physical location, currently the National University Hospital and NUS, the Kentridge station. And as you can see, the focus is very much on positive messaging, but also driving home the message that it's with early and effective treatment that people living with HIV can live healthy lives, no different than others. So trying to bring home this concept of early testing in order to benefit from the subsequent care, and as is reflected in the second and third 90s. And the last bit that I wanted to speak about, because it's impossible to get away from this, is what has the landscape here in Singapore looked like around since the advent of COVID-19. Our HIV treatment services are primarily based in hospital clinics. So that was significant because clearly the major hospitals where ID and HIV, infectious disease and HIV physicians primarily work and provide care for PLHIV were the settings that were most impacted by the COVID pandemic itself. So we had to defer excuse me, non-urgent admissions, non-urgent outpatient visits to more than half, depending on which phase of the pandemic response we were in. And there were other constraints as well in terms of how we could deploy our manpower. How did this work? I think, you know, looking not quite in hindsight yet, I suppose, because we're not out of it, but looking at the data so far, it was able to be affected reasonably well across all our treatment sites, looking at differentiated care, differentiated needs of our population. So looking at newly diagnosed PLHIV who clearly would not have their hospitalizations or workup or investigations delayed in order to achieve positive outcomes, looking at stable PLHIV where spacing out of appointments, delinking ART provision for medical care could be done and telehealth could be provided very safely, versus people who are living with HIV but have their condition is either unstable in terms of the HIV or their comorbidities that are unstable. So being able to look at the different populations and tailoring care around their needs was something that was done across all the treatment sites in Singapore. Just in my last couple of slides, although I think it's been mentioned by others as well. So challenges, of course, have been many. Uncertainty of the COVID how COVID would affect people living with HIV early on, and even around what the vaccine response would be in PLHIV, depending on the level of immunosuppression or unknowns that the healthcare system and people living with HIV themselves had to cope with. The ART supply, thankfully, we haven't experienced stockouts here in Singapore, but there was a fair number of patients who might normally get ART from overseas because of cost, who clearly were unable to travel, and how we were able to engage those through our pharmacies was important at the time and remains important even now. Pharmacy delivery can be a challenge. Privacy and confidentiality has been mentioned and cannot be underestimated as a threat to the continued health of our patients. So how do you deliver antiretrovirals to somebody's home when they're not disclosed to their family or their housemates, for example? And in terms of telehealth, even though again, it can be looked at very positively as a solution to several things, it's not a panacea, as Adiba also mentioned. Finally, what are some opportunities because of COVID-19? There has been increased acceptance of this concept of differentiated care and ART delivery in our population. There had been barriers in the past, both from patients, clients, and providers. And because of COVID, there has been an accelerated curve to both the acceptance and the adoption of these services. And I think has served to smooth out some of the teething issues. Finally, there is an opportunity for us to speed up the implementation of HIV self-testing in Singapore, although a demonstration project that has been planned for a while was put on hold because of COVID. On the other hand, perhaps its subsequent implementation will be smoother because the public is very much used to now self-testing for an infectious disease because of the COVID ART kits, antigen rapid testing kits being available so broadly in Singapore. And that brings me to the end, a bit of a rush, but again, I look forward to the Q&A session. And I'd like to invite everyone who would like to join us this coming Saturday. We have the second part of the Singapore HIV Congress, and you can hear among the many speakers, you can hear Professor Adiba again talk about or delve more deeply on HIV stigma, HIV-related stigma in our region. Thank you so much.
Great talk. Thanks so much, Sophia. And I believe the great work done by Singapore National HIV Program can be a kind of great lesson learned for our colleagues working on HIV as well. So we have heard about the overview of HIV in the global level, regional level, national level. So let's move to further down to hear the voices of community. I would like to invite Dr. Reiner Tan, who will share his community perspective on the overview of inequality in access to HIV prevention and care services among key population, focusing on laws, stigma, and discrimination as barriers to ending AIDS in Southeast Asia. Dr. Tan is Director of the Greenhouse Community Services Limited and President of Sunshine Initiative Singapore Core Project X. He is also a postdoctoral fellow at the University of North Carolina Project in China and visiting research fellow at our school, Southfield School of Public Health of the National University of Singapore. Please, Dr. Tan.
Thank you so much, Zian, for the introduction. So for many of my colleagues, many of you will know me as a researcher first. Currently, as Zian mentioned, postdoc at UNC Project China. I'm working on social innovation and health projects with key populations in China currently. Also working with youth on a global scale through partners like TDR Global and the WHO, and a visiting research fellow at the Saucy Hawk School of Public Health and NCID in Singapore. And my research expertise on the application of social theory and perspectives in health. But today I will not speak to you as a researcher or scientist on this panel, but speak as a community representative. I represent community-based organizations like Project X and the Greenhouse, and among many other groups who are instrumental in the local HIV/AIDS response. But I want to take the first few minutes actually to share more about my own story, my own biography as a cisgender gay man growing up here in Singapore. Some content warnings include sharing about suicide, HIV, and other complex traumas. I knew I was gay when I was about 10 to 11 years old. What I knew back then at such a young age was that this was wrong and abnormal. I hid this part of me for a long time. It was almost like I started to dissociate my identity into two diverging worlds. One where I was finding out more about my sexual orientation or sexuality, and one where I concealed my identity from everyday life. I knew there would be a price to pay if these two worlds ever crossed, because I thought to myself that being gay was such an abomination. I spent a few years trying my best to convert myself. I tried having girlfriends and approached religious institutions, mentors, and friends about this. I did not want to be gay. Self-loathing coupled with bullying in school led to many years of depression, loneliness, and a point in time where I had tried to attempt suicide when I was 15 years old. I came out to my parents when I was about 16, which negatively impacted our relationship. And at that point in time, for a while, I felt safer to move out and stay with my then boyfriend. I did not feel like I could approach anyone to talk about the struggles or uncertainties of being gay. So the internet became a treasure trove of information. I got to know some friends there and started hanging out with other gay men. It was also during this time that I became sexually active. And to be honest, I enjoyed it because that was the only way I knew how to find intimacy with others. It helped me deal with my loneliness, and however fleeting it was, I felt loved and supported in spite of my sexual orientation. Throughout my teenage years, I was also really, really afraid of HIV. I knew the risks and what it meant for me if I ever got it. I spent most of my teenage years being paranoid about getting HIV and STI, so I got tested really, really regularly. I was even recruited into a research study by NUS once when I was 16 or 17. And I recall, and I managed to get a free full suite of testing back then. So when I was 20, I met someone and began dating this person. After 2 weeks of dating, I felt like I could really trust this person. While I never engaged in sex without condoms among my casual sexual partners, I thought that this person was someone that I could trust. He suggested having unprotected sex, and I decided to go with it. Naturally, being paranoid about HIV and other STIs, I felt terrified after having sex. I knew the risks of HIV, so I spent the next 24 hours trying to deal with the emotional aftermath of the situation. I knew at the time that there was treatment for post-exposure prophylaxis for HIV, so I Googled and I went to see a nearby general practitioner for advice. I didn't know where else to go, and I was terrified of going to government clinics for fear of being found out, for being gay, for being deviant, for being a criminal, in fact, in Singapore. Since I wasn't sure what my partner's status was, the doctor told me that it was up to me if I wanted to take post-exposure prophylaxis. It would have cost me several thousand Singapore dollars to access this treatment at private practitioners. And that was when I was faced with like a terrifying situation. I just couldn't afford it. I couldn't approach my family for fear of being thrown out. I was terrified of approaching anyone else because, what would they think of me? Someone who was morally deficient, someone who was promiscuous. Back then, the risk of the two worlds colliding outweighed the risks of getting HIV. But a few weeks later, I fell really ill, and a few months later, I tested positive for HIV. My world collapsed, and it led me to several years of deeper isolation and self-loathing. I became dependent on substances as a way to cope. I dropped out of university, my bachelor's degree, and a few years later ended up in rehab, which was actually a blessing in disguise, as I was literally dying and wasting away due to injection drug use and prolonged dependence on substances. So during the early years of living HIV, I sought intermittent care in Bangkok actually for many years due to a fear of being registered in Singapore as an HIV positive person. I only began taking medication for 4 years later, actually, after I was diagnosed, because of a lack of money and a deep-rooted fear of acknowledging, above all to myself that I was HIV positive. So, but then today things are different. I've lived with HIV for about more than a decade, and I no longer allow myself to be defined solely by my HIV status. Today, I'm surrounded by loving people who tell me that in spite of what others think I have value, and I'm not defined by the stigma associated with being gay or being HIV positive. But it took a lifetime for me to get where I am. I am still a privileged HIV positive gay man, and I cannot imagine how many people have it worse. So every year we kind of see these numbers on our charts, and we've seen a lot of data, being pushed out by research institutions and even people like myself, who I'm a scientist and researcher, primarily, and it's easy to forget that each number here reflects a story or a journey like mine. In fact, this is me on the top left-hand corner, right here, our 2013 data on HIV when I was finally linked to care. So I'm part of the 454 new cases there. In ASEAN, according to the ASEAN report on good practices and new initiatives in HIV and AIDS, it's estimated that 75% of incident HIV infections occur among key populations. These include MSM, trans people, people who inject drugs, other vulnerable populations, such as partners of key populations, youth and mobile populations. In the same region, laws criminalizing key populations and that create barriers to accessing care still prevail in many settings. And while these laws serve as a form of social control in some places, they also criminalize and punish men who have sex with men, transgender people, people who inject drugs or use drugs, and sex workers for existing and trying to survive. These laws also reinforce and reproduce stigma towards such groups. In spite of social contracting that takes place in several settings to allow for HIV-related services among key populations, this is clearly not enough. Domestic and sometimes even international funding often fail to reach such key populations in many settings because of such laws and stigma. We should have all the tools to already end the HIV pandemic, but we are failing to implement them because of such stigma and discrimination. Within this backdrop, are we surprised that the epidemic continues to persist among key populations? So barriers to HIV prevention and all parts of the 90-90-90 or 95-95-95 cascade remain. Over here, we see an infographic by Avert showing data on the 90-90-90 cascade for the Asia Pacific in 2019. And while it looks like we are almost at 90-90-90, what this really means is that overall, only about half of the people living HIV in the region have not achieved viral suppression. This is because a key challenge in the region is getting people to know their status and to be linked to care in the first place. Access to HIV prevention like PrEP and PEP, or pre-exposure prophylaxis and post-exposure prophylaxis, remain out of reach by many who face stigma, and like me, whose worlds are threatening to collide. Many sex workers even face issues accessing condoms, as it is often used as a form of evidence to prosecute someone for conducting sex work, especially in places where sex work is criminalized. Many key populations are also not served by health services that target a general population due to the fear of stigma. This is exacerbated by the lack of comprehensive sexuality education in many settings, which lead to deeper inequalities for key populations. Like me, many are left to figure out things out on their own. Individuals living with HIV face barriers also towards medication adherence and achieving viral suppression in this region for the same reasons of stigma, self-stigma, and discrimination. So we also talk about the fourth 90 sometimes, the quality of life among people living with HIV. People living with HIV cannot achieve a good quality of life, especially with social stigma, the lack of anti-discrimination legislation, and counterproductive laws that are not evidence-based, which threaten criminalization and the well-being of many people living in HIV, and they ultimately create barriers towards linkage to care. So this is my version. It's not a Ken Rich, it's Kaki Bukit. And it's actually by a friend. So ending AIDS is really a multi-partite effort among policymakers, scientists, and especially communities. We always say nothing about us without us. Every day, I believe that we are taking important strides towards equality of outcomes and one of health equity. And so this picture shows an ongoing campaign in Singapore right now to destigmatize HIV and to educate the public. One of the most impactful island-wide campaigns in Singapore we have seen. And I say that emotionally and viscerally because we don't have data on the impact yet. And that's my occupational hazard speaking, which was a product of a collaboration actually between community representatives, clinicians, and policymakers. So as a community representative, a person living with HIV and a scientist, this is a call for policymakers and governments to walk the talk, align themselves with the scientific evidence. This means taking steps towards meaningful engagement of key populations and providing adequate funding and support to those at risk of and living with HIV. So it's also a call to end structural violence to key populations and people living with HIV. This is the way to end inequalities and to end AIDS and pandemics today. All right, thank you so much.
Thanks so much. I think I and I believe everyone in this room was moved by your story. Thanks for sharing. And I believe the voices of the community should have been more widely heard and their health issue inclusively addressed as we aim to end the inequalities in access to HIV prevention and care services in vulnerable and marginalized population. Thanks so much, Rena, for your great talk and sharing your stories. Next, I would like to invite Dr. Fernando to share his insights on the health priorities of the Association of Southeast Asian Nations, ASEAN. particularly in the fight against AIDS pandemics in the region. Dr. Fernando is Assistant Director and Head of Health Division, Human Development Directorate, Asean Secretariat. Under his purview, is the facilitations, coordination, initiations, management, and implementations of the ASEAN's health development agenda, and its work programs focus on health priority. Please, Dr. Fernando.
Thank you very much to NUS and also UNAIDS for inviting me here, and also personal appreciation for the personal sharing of Mr. Rainer Tan. I have dear friends and colleagues and relatives who are living with HIV. Thank you for allowing me to share the relevant updates at the regional level regarding ASEAN health sector cooperation on HIV and AIDS. And thank you for the assistance from the Secretariat of NUS for moving my slides. Next slide, please. Thank you. This presentation will cover the following 4 major topics: the development agenda, cooperation HIV/AIDS, Cities Getting to Zeros project, and our intervention in the United Nations high-level meeting on HIV and AIDS last June 2021. Next slide, please. With regard to the ASEAN post-2015 Health Development Agenda for 2021 to 2025, please be informed, next slide, please, that HIV and AIDS is based on a higher mandate of implementing 42 strategic health-related measures in our ASEAN Sociocultural Community Blueprint. Next slide, please. Particularly, through the ASEAN Post-2015 Health Development Agenda, we are implementing the 42 health strategic measures operationalized through the vision and mission as shared in this particular slide. Next slide, please. The development agenda has 4 ASEAN health clusters and 21 health priorities. Initiatives on HIV and AIDS are included in Health Priority 8 as highlighted in this slide. However, allow me to also reiterate that there are other ASEAN health priorities from the other 3 health clusters that are related to the initiatives on HIV. This would include initiatives on migrants' health, universal health coverage, as well as reproductive health initiatives. Next slide, please. Then the implementation of HIV and AIDS in the region is still under the purview of the ASEAN Health Cluster 2 country coordinators represented by contact points from HIV and AIDS in each of the ASEAN member states. This is the current governance and implementation mechanisms wherein HIV and AIDS are implemented and are monitored. Again, allow me to reiterate, this is under the ASEAN Health Cluster 2 and currently being implemented and monitored at the regional level through the respective country coordinators and HIV and AIDS contact points from each of the ASEAN member states. Next slide, please. With all of this being mentioned and shared, allow me to share with you an overview of the ASEAN health sector on HIV and AIDS, particularly, next slide, please. The work program of the ASEAN Health Cluster 2 for the period of 2017 to 2020 includes 15 HIV and AIDS related activities that addresses the commitments on fast-tracking HIV and AIDS response, sustaining HIV and AIDS response at the regional level, implementing Cities Getting to Zero initiatives, as well as strengthening capacity in strategic information and evidence-based advocacy. There are already completed activities that have been led by this by the ASEAN member states. Next slide, please. Primary focus for the next 5 years or the next work program, including HIV and AIDS, is to implement the follow-up activities from the completed activities that I have showcased in the previous slide, as well as ongoing upcoming activities, which would primarily include, among others, the promotion of community-based testing and treatment, reaching key affected populations, including the young people, as well as follow-up initiatives on HIV and AIDS investment cases among the countries. Next slide. Thank you. For the next 5 years, primary implementation will also include the NUSA DUA call for action, which would pursue initiatives on city-based networking on ending AIDS. This is highlighted in the slide in front of you, and this would include an establishment of a virtual sharing or learning space for ASEAN cities led by Indonesia, as well as organizing ASEAN City Sessions in the annual Fast Track Cities Conference to be led by Indonesia as well. Next slide. With regard to the ASEAN Cities Getting to Zeros project, allow me to update you about the following matters. Next slide, please. The implementation of the ASEAN Cities Getting to Zeros project, which started from 2012 until the present, was started with only 13 pilot areas or cities in 2012. This was scaled up to 13 pilot areas, and now this has been scaled up to more than 50 cities or areas as of this time. Thank you. Next slide, please. The ASEAN Cities Getting to Zeros project, which includes more than 50 cities and areas as shown in the previous slide, was made possible as a realization of the ASEAN Declaration of Commitment that was adopted at the 19th ASEAN Summit in 2011. This was then superseded by the ASEAN Declaration of Commitment on Ending AIDS by 2030 that was adopted at the 28th ASEAN Summit in 2016. Next slide. This particular ASEAN Cities Getting to Zeros project are composed of 3 phases. The phase 1 was the implementation of this project in the 13 pilot areas that I have shared with you earlier. Phase 2 would include initiatives in these 13 pilot areas that were continued and scaled up to other areas based on the lessons learned from the pilot areas. Next slide, please. The phase 3 focused on cities network as well as the development of the NUSA call for action. This was primarily, the development of the NUSA DUA call for action was primarily conducted in 2019, participated by stakeholders as well as local government unit representatives such as the mayor's level in 2019. This was also participated by our dear colleagues from UNAIDS. Now moving on from phase 3, next slide please. Then the implementation of the NUSA DUA call for action would focus on strengthening South-to-South collaboration or cooperation among the ASEAN member states and among the cities that are already part of the scale-up operation of the Cities Getting to Zeros project, as well as similar initiatives from the regional level will be implemented at the city level, as shown in the slides. Now, sustaining and also strengthening or enhancing further gains from these regional initiatives at the ASEAN level. Next slide, please. We have advocated all of this gains and initiatives at the United Nations High-Level Meeting on HIV and AIDS in June 2021 by, next slide, please, showcasing the ASEAN health sector position. This was read by the current chair of the ASEAN health sector, Indonesia. And in this particular event, the ASEAN health sector reaffirmed the long-standing commitment to ending AIDS in ASEAN by 2030 through regional response mechanisms. And the statement also is aligned with the commitments of ASEAN to the global AIDS strategies for 2021 to 2026 in ending inequalities and ending AIDS. Next slide, please. For the World AIDS Day observation tomorrow, the ASEAN Health Cluster 2 chair through the leadership of Philippines will be showcasing the statement for the WAD message, which would basically include initiatives or highlights regarding the adaptation and innovation towards a resilient HIV and AIDS response. This would also include the continuity of essential HIV and AIDS and healthcare services through differentiated service delivery models, such as the multi-month dispensing, optimized use of virtual or digital platforms, community-led and home-based delivery of services, with special attention to the poor, disadvantaged, and marginalized communities, and also acknowledging that poverty and poor health are linked, and that poverty can increase the risk of progression from HIV to AIDS. With that being said, thank you very much for your kind attention. Over to you. Thank you.
Thank you so much, Dr. Fernando. I think these are very important informations hearing from the Asian secretariats in terms of HIV response in the regions. I have not heard very much at that level, actually, Asian level, and this is very important. And I'm sorry for the delay. We have to probably spend about 10-15 more minutes for Q&A. I mean, probably we tried to, I believe, thanks to our panelists, Prof. Adiba in particular, have answered several questions already, and that's very helpful and save a lot of time. And so we will go quickly to the question, and then we will have two speakers for closing session. I think, yeah, only the first is questions from, I think Prof. Adiba already answered. I don't have to go through that. Let me screen over to these others. Almost all have been responded, actually. Have I missed any question? Martin, I think Prof. Adiba has answered all the questions, I believe. And
if you want.
yeah, thanks so much. Thanks so much. And yeah, this is perfect save for. Then I think we can move directly to the closing sessions. For these sessions, we have two kind of yeah. We have, sorry. Okay, so it comes to the closing session. So this I think it's a good time because although we have heard a lot from a kind of HIV programs and the voices from community, but we believe it would be great to hear more from the community perspective, and we have invited two speakers. One is Mrs. Ika Noviyanti from Youth Lead Indonesia, who is going to share her insights and reflection, particularly on inequalities in access to HIV prevention and care services among youth in Southeast Asia. Mrs. Noviyanti is the advocacy officer at Youth Lead, working with young key population networks at national and regional levels. She brings attention to the specific needs and issue of young key population and works to empower young people as leaders in HIV. Ika also provides technical support and mobile resources to youth-led organizations at the country level. Please, Mrs. Noviyanti.
Thank you so much, Sian. I hope you can hear me all right. So hi everyone, good morning, good afternoon. My name is Ika Noviyanti. I'm from Indonesia and I'm speaking on behalf of young key population in Asia and the Pacific. So I'm currently works as an advocacy officer for Youth Lead, the Asia Pacific of young key population. It really is an honor for me to participate in closing of this webinar. So this year, as we all know, is the 40 years since the first 5 cases of what later became known as AIDS were officially reported. Some countries, include some with the highest rates of HIV, have made remarkable progress against AIDS, illustrating what is feasible. However, new HIV infections are not falling fast enough globally to stop the pandemic. We, the communities and young people, have been at the front line and have shown that we can lead the services, but community response remain under-supported and underfunded and held back by restriction. We, the young population, are put higher risk because of the laws and policy which criminalize us and stigmatize us. During the COVID-19, we have been trying to protect the gains made in the HIV response, ensuring key population and people living with HIV had access to HIV services. As we all know, that we are currently living in digital era, many companies are already operating in digital way, but not in the health sector. We heard from Professor Adiba on how digital prevention as means to end inequality. Digital health has many benefits for prevention, treatment, and also reduce stigma and discrimination through the digital work. But after all, there is still a lot to be done to make digital health a success. But we cannot do this alone. We need support from the government and the leaders. Today, let us all go away from this webinar with one mind that the best way to end HIV/AIDS is to invest on community-led and community-based organization, support community and young people to engage in the program. And the most important thing is to work together with stakeholders across all levels. Thank you. Back to you, Sian.
Excellent talk, Ika. Thank you so much for your amazing reflections on the need of young key population, most vulnerable to HIV and other related health issues. Inequalities in access to health among them have been a kind of well evidence across the world. And these are very important. Thank you for your great job as well. Last but not least, I would like to invite Mr. Midnight Punkaset Watana to provide his closing remarks on the webinar. Midnight is Executive Director of Asia Pacific Coalition on Male Sexual Health, short APCOM, based in Bangkok. He works on advancing sexual orientation, gender identity, expression, and sexual sex characteristic rights in the Asia Pacific region. Midnight serves in advisory committee, including the International Day Against Homophobia and Transphobia Committee, World Health Organization's Global PrEP Coalition and Guidelines Development Group for HIV Testing Services, and ASHM's Regional Advisory Group member leading on key population of the Task Force on BBV, Sexual Health, and COVID-19. He was invited to give closing plenary statement at the high-level meeting on ending AIDS at the United Nations General Assembly in New York in 2016. Over to you, Midnight.
Sawasdee krab. Thank you so much, Sian, and thank you to the organizers in US and UNAIDS for inviting me to give a reflection on this very important topic for World AIDS Day. I want to first say thank you to Ika, and for those who didn't know yet, Ika is the latest recipient of the Hero Award for the Young Achiever category. The award recognizes the work of a person living with HIV under the age of 30 who has improved the lives of people living with HIV. So I'm so honored to be part of this World AIDS Day session with you, Ika. And congratulations again for being the beacon for young people with HIV in our region and also for the rest of the world. I also want to applaud and thanks Rainer for his courage and leadership for sharing his personal stories and bringing the human face to these very important discussions. We have seen during COVID-19 how important community-led responses have been for the community-based organizations in terms of reaching those that have been pushed even further to the margins due to the inequalities and cannot access social safety nets. We have seen the community providing food, water, cash, shelter, refer to services, and being the voice of the marginalized and raising awareness of the inequalities faced by their communities. So the recently adopted 2021 political declaration, we have seen some very welcoming commitments when it comes to the communities. So commitments to increasing the proportion of HIV service being delivered by the communities to ensure that by 2023, community-led organizations will deliver 80% of HIV prevention services. There is a commitment to build on the resilience and innovation of community-based health systems during COVID-19 pandemic. And there is commitment to investing in community-based emergency response infrastructure and providing strengthened community ownership during health emergencies. As all the other speakers mentioned, the ASEAN region, even despite a lot of restrictions in the enabling environment for key populations in particular, when it comes to programs implementation, we are one of the first to adopt them. However, we need to be better at scaling up such innovation So I'm talking about pre-exposure prophylaxis as key component for combination prevention and needs to be made available for those that would be beneficial for them. We need to also make knowing your HIV status much more accessible, which means making HIV self-testing more available. Much more needs to be done around stigma and discrimination and moving away from the numbers and seeing the faces rather than the figures for reporting. The 2021 political declaration has a strong language on scientific evidence demonstrating that people living with HIV who are on antiretroviral treatment and maintain an undetectable viral load do not transmit sexually HIV, also known as U equals Q, undetectable equal untransmittable. So we need to be able to leverage this breakthrough to work through to the vision of zero stigma and discrimination. And from 40 years, we know that not enough is being invested into community-led organizations and programs, and their resiliency is on the brink due to COVID-19. It is estimated that Asia and the Pacific region requires 32% of the total global resources needs, particularly for HIV prevention. Thus, ending AIDS will require substantial additional domestic investments, reinvigorating international contributions, more efficient allocations of available resources and creative solutions, and working together with the communities, making sure the communities is part and also equal partnership in ensuring that we will end the epidemics together and also in times of the pandemic as well. Thank you very much. Sawasdee krap.
Excellent closings on Remark and inspiring work, Midnight as always. And congratulations to ICAP for the awards. You deserve it, and you should have included in your bio actually, so that we could congratulate you properly. Thanks so much, all the speakers and audience. Let me conclude the webinar. After 40 years of our war against HIV, the epidemic continues to threaten the world. Economic, social, cultural, and legal inequalities must be ended as a matter of urgency to end AIDS by 2030. Political, economic, and social policy need to protect the rights of everyone and pay attention to the needs of disadvantaged and marginalized communities. On this World AIDS Day, let's remind our governments that global inequality affects us all, no matter who we are and where we live. This World AIDS Day demands action to end inequality in access to prevention and care services for HIV and other pandemics that thrive on inequality. On behalf of the organizing committees, I would like to thank the panelists, speakers, and audiences for your contribution and participation in this webinar. We also thank UNAIDS for the joint effort in convening this event. And just a quick remindings, our video webinar video record will be available shortly on our school's website. So we look forward to seeing you all again at a future occasion. Thank you so much again.